This is the University of Otago.
I'm introducing today and I'm reading it because they're so fabulous I can't actually learn it off by heart. So the two speakers we have today are Sarah Derrett and Marshall Chin. I'm not sure if you've met Marshall, but everyone's probably familiar with Sarah. I'll still introduce you. Sarah Derrett is an associate professor here in the Department of Preventive and Social Medicine, where she teaches health systems and public policy, and she's also the director of the Injury Prevention Research Unit. Sarah's research is focused on patient-reported health, social service pathways, and the experience of patients in the health system. In 2011-12, she was a Commonwealth Fund Harkness Fellow based at the University of Chicago, where she examined care integration at remote rural health clinics and community health centres in the US. She is a member of the Euroqual Scientific Committee, sits on the executive of Bowel Cancer New Zealand, is on the board of Kuputai Lodge, a community mental health respite service provider, and is a member of the Community Health Council. Hence why I couldn't remember all of that. Marshall Chin here is a William Evans Visiting Fellow hosted by the department here at Preventive and Social Medicine. He is a Richard Parillo Family Professor of Healthcare Ethics at the University of Chicago, an expert in health equity, general internist and health services researcher with extensive experience in improving the care of vulnerable patients with diabetes and other chronic diseases through the healthcare system and community interventions. Marshall is a graduate of Harvard College and the University of California at San Francisco School of Medicine. He completed his residency and fellowship training in general internal medicine at Brigham and Women's Hospital, Harvard Medical School. So the talk today is Integrating Care in New Zealand, Lessons from the United States, Oxymoron or Actuality. Sarah will be talking first, followed by Marshall. We'll see if there's time for questions at the end. There may not be, but you can always talk to them afterwards. Thank you.
Thanks very much, Trudy, and tēnā koutou katoa. We're delighted to be able to give this talk to you today on integrating care, oxymoron or actuality. I mean, is it even possible for us to learn anything from a system as interesting and complex as the United States? Today we're going to be looking at integrated care, and is this occurring within New Zealand's healthcare sector, and if not, why not? And then I'm going to go very briefly through a New Zealander's snapshot of the US health sector, focused around a case study of integrated care that I did with Marshall and others when at the University of Chicago, focused on rural safety net clinics. And then I'm going to hand over to Marshall, and we'll look at the lessons from the US examples of integrated care. Oh, I'm sorry about that. I didn't mean for that effect to happen. So, as we all know, health systems are very much influenced by the history and the origins of those systems. So, just to look very briefly, in New Zealand, with the arrival of settlers from the late 1700s through, we saw the establishment of the first hospitals in the 1840s, so just 7 years after the Treaty of Waitangi. And this picture here is of the hospital that was established in New Plymouth in 1848. And in fact, if any of you have been to Pukekura Park in the centre of New Plymouth, there's part of this original hospital is located just behind the tea kiosk, so it's worth visiting if you're ever in New Plymouth. Then, of course, one of the most foundational documents for New Zealand's health system was the Social Security Act, introduced under Michael Joseph Savage's leadership of the Labour Party back in 1938. And that legislation saw the core principles for healthcare in New Zealand, which is still in place today. That healthcare should be a fundamental right, that we should be able to easily access services, and those services should be universally accessible, so not just for the wealthy, that there shouldn't be barriers. The health system should have a preventive rather than a curative focus, and that services should be integrated, which is the subject of our talk today. However, as many of you will know, that post-1938 we didn't end up with an integrated healthcare system. So general practitioners argued that it was important for them to maintain their independence from a state-funded healthcare sector and to remain private business owners and operators. And there were several reasons for that decision, but one of them was that they actually wanted to be able to care for their patients independently of government meddling or interference as they saw it. But the outcome of that has been that we've got different healthcare providers working in separate systems in New Zealand. We've got people working in publicly funded organisations, privately funded organisations, and we've also got complexities in our small country's healthcare system according to the services that are located in primary care services, GP clinics, hospital-based services and community-based services, and we have different funding streams to exacerbate this. So even though our population's small and our country's small, we have quite a complex system that is a legacy of that post-1938 bargain in part. Integrated care matters. Integrated care matters for patients with chronic and complex conditions, and often the focus of integrated care is for these complex people with multi-morbid diagnoses. But integrated care may also prevent the development of chronic conditions in the first place and may lead to the timely diagnosis and appropriate intervention for acute onset conditions also. So in the next slide, I just want to look at what we are meaning by the term integrated care, at least in our talk. So Sarah Singer and her colleagues from Harvard developed an integrated care framework, which is quite interesting in that it takes into account both care coordination aspects as well as the concept of patient-centred care. And there were 7 constructs in their framework which we've used, and so I won't go through all of these in detail because time doesn't allow, but this was the sort of underpinning framework that informed the analysis of the case study. So given the known challenges faced by the US, can there be any lessons for us here in New Zealand? Is that even possible? So we know that the American healthcare system is the most expensive in terms of the OECD countries, and their costs have done nothing but increase. There was a little bit of flatlining post the economic recession, but it's increasing again. New Zealand is here in black and with a bit of a dip post 2010. So the American system's complex, it's very expensive. There's also a very in the OECD countries, America has the highest out-of-pocket or privately funded healthcare system compared to New Zealand down here with a smaller, still a significant proportion, but a much smaller proportion of out-of-pocket payments funding our healthcare system, which in New Zealand is sitting at around a bit over 16 billion per year at the moment. In terms of issues, the New Zealanders in the room will be well aware that these issues commonly come up in the media. So issues of timeliness of provision of services. I mean, there's been an awful lot in the media just locally related to the Southern DHB and challenges that they've been facing lately. Quality of services when things go wrong. Access to services. So we know there are many, many examples of GPs referring their patients into the secondary service and not being able to get their patients into the system or having very lengthy waits for that to happen. And we have ongoing issues of communication between primary and secondary providers. This is not a unique to New Zealand phenomenon, but our electronic healthcare systems, there's an awful lot of work being done at the moment to make those connect in a better way, and we're beginning to see in the Southern Health District, we're beginning to see the introduction of patient portals and greater involvement for patients in health IT as well, but we're still a long way away from a truly integrated health IT system, and that leads to problems in terms of patient support and tracking and following patients over time. So these are considerable issues that we face. In New Zealand, we have a two-tier system, so even though a smaller proportion of our health spend is out of pocket, we still have differences in terms of equity of access to services according to whether or not people can pay privately for perhaps diagnostic procedures in the private sector and then gain faster access to the publicly funded system. And even though our system is cheaper than the US healthcare system, there are particular challenges that we have also in terms of patient engagement managing chronic conditions. So you can see here that a very high proportion of New Zealanders who have a medical home, so are enrolled with a GP practice, a high proportion are saying a low proportion are saying that they're satisfied that their health professionals have done these things, have discussed their health goals and priorities, have helped them make a treatment plan that they could implement, and have given clear instructions on symptoms and when to seek care. And in fact, the US is doing better than us in that respect for patients who are enrolled in a medical home. But even for patients not enrolled in a medical home in the US, they're performing better than us in that regard. So now I'm just going to quickly move to a little snapshot of the case study that I did in the US that was focused on integrated care. And Marshall asked me before, is that a picture of America or New Zealand? And I said, it's clearly a picture of America, just because of the size of the silos, it's huge. So this case study was focused on integrated care in rural clinics. And the reason for the focus on rural clinics is for some of our rural communities here, underemployment and poverty was certainly an issue in the States, and underinsurance in rural communities as well. So in America, insurance is often tagged to your employer and your employment, and so with underemployment, we saw underinsurance. And these communities are often a very long way away from secondary healthcare providers at least, and so they often face major transportation difficulties. But even within their local rural communities, people can be living a long, long way away from the small town where the primary care clinic is based and not have access to, don't own a vehicle, and there's no public transport, so those sorts of issues. And lastly, just little was known about implementation and strategies for integrated care in rural settings, so that was the reason for the study. Marshall's going to come back and talk a bit more about the medical home safety net project as a whole, but safety net clinics are really provided to give health services to the most vulnerable populations, and so they're located in particular regions throughout the US, including rural areas. And so we wanted to look at challenges faced by integrated care, challenges faced in terms of integrating care in rural clinics and the strategies that they use to address this. So the first centre that we went to was the High Plains Community Health Centre, and you can see here it was a terribly long way from Denver. It was a really interesting drive to get there across the high plains of Colorado and via the Garden of Gods, which if you're ever in that part of the States is well worth visiting. But an awfully long way from Denver, which was the main site for secondary and certainly tertiary healthcare for people living in Lamar. But the other interesting thing is the very, very low median income. And so it was literally a situation of houses with broken windows and doors hanging off the frames and much, much underemployment in that community. The next place in the case study was OHSU in Scappoose near Oregon. Slightly higher median income, but still a community very much affected by a decline in the logging industry and other things. And lastly, East Oregon Medical Associates, which was in a little town of Baker City, again a very, very long way away from Portland, Oregon. It was a 5.5-hour drive to get there. So I'm just going to focus now on looking at the different ways in which the safety net clinics configured their services, which was quite interesting to me as a New Zealander, quite different to how our GP practices are configured here. So each of them, each of the clinics had a slightly different structure, but probably some different roles co-located in each clinic to those that we might ordinarily find in our routine primary care facilities here. So I'm going to focus mostly on the High Plains Clinic, just in the interest of time. Each of these safety net clinics had really unique and interesting features about them, but High Plains, what was interesting was the independent caseload. So first and foremost, if people were MDs or physicians, nurse practitioners or physician assistants, they all had their own independent caseload, so we're practicing as independent providers. So the nurse practitioners weren't just working, following the GP's instructions, they were working independently. There were a few caveats around that in terms of certain few items that they weren't able to prescribe, but by and large they were entirely independent. In the clinic was also a team of patient facilitators who received about 18 weeks of training to be able to do a number of tests and support work to help the providers. So when patients came to the clinic, they would screen the patients first, take any tests or diagnostic tests that they would then pass on to the clinician. They also had co-located at this clinic a health coach, and that was someone who would pick up after the person had seen the clinician, and perhaps they wanted help with exercise programs or weight loss or needed diabetes support. Those health coaches in the clinic would liaise with the patient and set up separate appointments to work with them closely on those issues. The health coaches also worked closely with the rural community, and there was one gym in the bar, and so they set up partnerships with that gym for people who were working on weight loss or exercise issues, heavily subsidised enrolment fees and programs for those people to go to the gym and participate in that. All the clinicians and the health coach would take it in turns to host a walking group that happened every Saturday morning in the local community, and everyone who wanted to would join that walking group and they'd go for a walk together. And they also had co-located behavioural health workers. I'd just like to read out a quote about that. I'm here to offer the piece of integrated care that's the behavioural health side, so they can have easy access to somebody. If a provider has a patient in their room who's struggling with mental health, it's kind of nice having me around so they can actually ask me to meet the patient right then and there. My field, behavioural health, mental health, has a horrible stigma, unfortunately. So it's nice to put a face with a name rather than just referring them without that face. It seems to make people feel a little more comfortable about the idea of mental health. It's part of what we call the warm handoff for mental health consultation. So that had been an initiative that came from the clinic. There was one mental health provider in this small town, and people reported a lot of sort of embarrassment or shame crossing the thresholds of that mental health provider. So instead they brought the provider in and co-located them in the clinic. So there's just a range of really, really neat initiatives that this remote primary care practice was able to implement. I'm only touching on a few of them, but these patient facilitators had a key role in following up to ensure that patients were able to literally get to the hospital appointment that might be in Denver, were able to fund the fuel for their car to get there, and if not, they liaised with local charities to make that possible. And one of the things that rural health services here and in the US can struggle with is providers staying in that clinic for a long time, so there can be a problem with high turnover of doctors and nurse practitioners. But one really important thing across all the sites was that the patient facilitators and the medical assistants, their equivalents in these clinics, tended to be people of the community, and they stayed there, and so they became the key kind of linchpin to the team. So these people might move, but these people stayed the same and provided the continuity of patient support. So I'm not going to go through all of those strategies because I've talked to most of them. I'm going to now hand over to Marshall for some of the lessons from the US, and just want to acknowledge the colleagues here and in Chicago have been involved in working on various integrated care projects with us. Thanks, Marshall.
Thanks, Sarah. It's sort of like going through memory lane hearing about the project. It's really nice. And I'd like to thank the Department of Preventive and Social Medicine for being my home over the past 2 months as a William Evans Fellow. It's been a great academic home. I felt very welcome and appreciate them being here. So as Sarah said, I'm a William Evans Visiting Fellow, and it's really sort of a nice parallel structure here where 3 years ago I was Sarah's mentor when she was learning about the U.S. healthcare system, and now Sarah's my mentor and I'm learning about the New Zealand healthcare system. Although Sarah is slightly geographically challenged, and she's trying to point to Chicago, but I think she's in the cornfields of Kansas. And Sarah had a great project that she chose well in terms of her site visits. So this is the Colorado area, and very beautiful. And a nice article that Sarah had out of the project for medical care. And Sarah with American cows. So during my portion of the talk, we'll go over 3 different things. We'll talk about 2 models of integrated care in the U.S. and their drivers, review the evidence base for these models, and one of the underlying themes is really talking about the importance of thinking about both care transformation and payment of care at the same time. And specifically, I'll give you a story about hospital rounds in New Zealand, talk about the 2 key trends, and then the 2 models I'll talk about are the patient-centered medical homes. We'll go over other aspects that Sarah started to introduce, and then something that I think is probably new here in New Zealand, accountable care organizations, give you a little bit of flavor of that, and with some take-home lessons. So about 2 weeks ago, it was on a Monday, I was fortunate that Tracy, one of the kidney doctors here, was kind enough to let me tag along during morning rounds. And this was very kind of her. That it was a very busy morning for her because that weekend there were a number of new admissions, and so the team of the 3 doctors were seeing those patients, and really some of them for the first time. And so it was really hectic at the time, and so they let me sort of tag along. And it didn't take long before I began to realize or have this feeling, well, am I in New Zealand or the U.S.? Because it was really the same. I mean, who were the patients that were being admitted? Older adults with multiple chronic diseases. Many had cognitive impairment. Many had social challenges. There were challenges that the patients had in terms of the hospital and then the referring region. Some issues in terms of the GP primary care interface with specialists in coordination of care, mixed electronic and paper medical records. For the patient who had to be discharged, then challenges in terms of where would they go and that planning process. Quite a few of the patients had a variety of social problems, and some of them were legal problems, and so you're coordinating them with these 2 other sectors. That's complicated. And then sort of a particularly nasty problem, both in New Zealand and the U.S., is this issue of handoffs. So I mentioned, for example, that there were a lot of new admissions over the weekend, and so there was no one on the team that had actually been one of the doctors that admitted them. And so they've actually studied this, and this is not surprisingly one of the highest risk periods when there's the handoff in care between different teams of doctors, really any country, and so much for clear reasons. And so you see, again, these are all coordination issues, integration issues, and so very similar across the 2 countries. So the handoff issue, when I was walking the hospitals, I even saw that there's a current quality improvement project looking at how do you improve this weekend handover system. So just a quick background in terms of like a U.S. care. So like New Zealand, there are a lot of small independent physician and group practices, so like some of the rural areas, like where Syria was, or some of the suburban areas. We also have a fair number of larger entities. So for example, these so-called managed care plans or integrated delivery systems. So these are groups of could be physicians, hospitals that band together and try to come up with a formal legal structure in which they pull together and manage care and negotiate contracts with insurance plans. And they often have a variety of different types of payment, of which one of them is called capitation, where sort of like your district health boards, where you get like a lump sum of money at the beginning, and then you're responsible then for allocating that money. There's also this concept of the preferred provider network, meaning that a different system or given plan might negotiate with a number of providers and hospitals and then select a subset of those providers to be within the network, within the plan, so that someone who had that particular insurance plan would either have to go to those hospitals or doctors, or if they didn't go to those doctors or hospitals, they would have to pay more in terms of out-of-pocket. So this all sort of leads to the issues of like how do you manage the population's health. And you see there's a whole variety of tensions that are inherently built into some of these different models. So one is this tension between cost and quality. So for example, if you have a set budget you get at the beginning, well, your incentive is to basically try to reduce costs because you have a set budget, but that may come at the cost of quality of care. Or access, so for example, it's preferred provider network, so you're limiting access. You're saying, well, we want you to go to this set of doctors or these particular hospitals, so you're limiting access. The theory, though, is that, well, you are trying to get the hospitals and doctors and the clinics who are lower cost or higher quality. So these tensions in terms of trade-offs. Okay, two key trends that are sort of at the forefront that are relevant for this talk now on integration and coordinated care. So first is this shift from so-called fee-for-service payment to value-based purchasing. So there's this image or this sort of like a metaphor we have of like a U.S. healthcare system payment, the two canoes passing in the dark, or I couldn't find two pictures of canoes, so I did kayaks here in the dark. And so has anyone ever been in a situation where you literally have one foot in one boat and another foot in another, and particularly bad if the boats are going different directions? So if you have, at some point, it's very unstable, and you're likely to fall and get wet or hurt in a bad way. And so the challenge here is that there are two systems of care which are passing in the dark here, which have very different incentives. So the predominant system for years has been fee-for-service, where basically the more I do as a doctor, I get paid more. So if I see more patients, I get more money. If I order more tests, I get more money. If I do more procedures, I get more money. So there, the incentive is paying for volume. That is gradually going down in prevalence, and what's sort of rising is the so-called value-based purchasing, where the goal there is to basically try to incentivize quality. So if I give higher quality care, if my patients have better outcomes, I get more money than if my patients have poorer quality outcomes. And related to value-based purchasing is the shift from fee-for-service to these so-called alternative payment models. I mentioned one of them, like the capitation and the shift to a global budget plan. And the two others I'll talk about next are examples then of alternative payment models. The idea with the alternative payment models is that, in theory, they should be more efficient because fee-for-service is probably the most inefficient system because basically the more I do, the more I get. And so it's an example, like 2 years ago, there was a major change in the way that the Medicare program, Medicare is the program that funds people 65 and older, which is very powerful because it's like 1 out of every 6 people in the U.S. And so it has so much market share that whatever Medicare does, oftentimes then the private marketplace will then sort of follow. And so they did two things back 2 years ago. One was that for their fee-for-service payment, their goal was by next year to make sure that 90% of that fee-for-service payment was linked to quality and the shift to value-based purchasing. The second thing, and the thing that they ultimately want to do more of over time, is a shift to these so-called advanced alternative payment models. And the goal there is that by next year, they want 50% of their medical payments to be in this system as opposed to the fee-for-service system. And again, the example we'll talk about are of this type. So that's where they want to go, these different models. And then, so related to this integration of care. And there were two drivers of integrated care in the U.S. So one is clinical. So you talk to clinical people and they say, well, there's been this rise of importance and quality of care over the past 25 years or so. So it wasn't on the radar screen 30, 40 years ago. Now there's much more talk about, well, what is quality of care? How do we measure quality of care? How do we create systems that reward quality of care? Similar to that, there are concepts of good care. So chronic care models, like one of the big ones that some of you may have seen this exact slide. One thing that Sarah reminded me of as we were putting in this presentation is that when Sarah was in the northwest part of the country, up in Oregon and Washington, one of the gods of chronic care models is a guy named Ed Wagner. So somehow Sarah finagled so that he was actually one of the co-authors on Sarah's paper. So, And then maybe the last 6 years or so, there's been a lot of talk about patient-centered care. So it seems kind of obvious, but that language really hadn't entered the U.S. in a big way until about half a dozen years ago. Then obviously, if you're being patient-centered, you have coordinated care, integrated care. And then the financial drivers that we just talked about, the shift from fee-for-service to value-based purchasing and these global budgets. Okay, so now I'm going to do a deeper dive into patient medical homes that Sarah gave a nice intro to. So in the U.S., the story goes back about 60, 70 years. And it's actually the pediatricians, the child doctors that were at the forefront. And so part of a pediatrician's panel are, the term in the U.S. is children with special health care needs. So these are children that have a variety of physical and developmental and cognitive disabilities that make their lives and their management and their home lives challenging. And so in some ways, like the traditional medical system, if it was purely medical, would fail these children. And so they had to come up with these so-called medical homes that were more comprehensive, that did a better job of linking healthcare, education, legal services, social services that help the children and their families. So the idea of a comprehensive medical home. Now here is my favorite definition of a patient medical home. I like it because it's kind of a nice qualitative description that gets at it's almost the essence of a medical home. So Diane Rittenhouse is a family medicine doctor in San Francisco, and she writes that the model combines the core tenets of primary care, first contact care that is continuous, comprehensive, and coordinated across the care continuum, with 21st century practice innovations such as the use of electronic information systems, population-based management of chronic illness, and continuous quality improvement. So in some ways, the traditional primary care plus these newfangled ways of improving care. So Diane further adds that one important cornerstone of this model is a focus on meeting the needs and preferences of patients. Remember Sarah's slide about patient-centeredness. Another is payment reform. So money is important. So payment reform that improves reimbursement to primary care practices and rewards high performance. So if you go now 10 years back in the U.S., the alphabet soup up there, those are 4 of the major primary care professional societies. And they band together to came up with these joint principles of the medical home, which when you read them, it's quite a bit of overlap with the 7 constructs that Sarah had from the Sarah Singer model. And so sometimes you see these visual diagrams where they'll take like each of these different concepts and have it as a building block in this picture of a home with these principles of enhanced access, improved safety and quality. So if we fast forward to like this year, these various standards and concepts have been updated over time. And so this is the most recent edition of NCQA, is like the major accrediting body for medical homes in the U.S. And so you'll see that there's a lot of overlap with the ones from 10 years ago, and a lot of overlap with Sarah's constructs, with slight sort of like tweaks over time. So team-based care, practice organization, so it dovetails quite well with Sarah's rural clinic story. Knowing and managing your patients, including connecting to community resources. So again, nice parallel with the rural work that Sarah did. Patient-centeredness, Sarah mentioned empowerment, the idea of seeing the same provider over time. Care management, patient-centered approaches. Care coordination, so things like I mentioned the Dunedin hospital example in terms of the challenges of coordinating medical records and tracking patients and results over time. And then this issue of like having a quality improvement process, measuring your performance and trying to continually improve things over time and measuring how you're doing. So this all sounds great in reality, or in abstract, I guess. But how do you become a medical home, or how do you transform from a place where there may be an abstract concept to being, for example, a rural clinic that Sarah visited? So I want to give you an example. Actually, it's the example that Sarah mentioned, that she looked at 3 clinics, and these were 3 clinics out of a total of 65 in 5 different states. And so how do they make these 65 state medical homes? Well, there's a group of like trainers that basically did everything in the 3rd bullet. They provided a variety of technical assistance. So this is long distance part of it. So some of it's going to be through webinars and website resources. Some of it was local. So each state had a so-called cluster coordinator who would then be more local, who could provide coaching, one-on-one coaching. You could do site visits where it actually go to those clinics. And then there's the idea of the learning collaboratives. So these were based on a state level, so that any given state would have 12 or 13 of these clinics, and they would meet in person anywhere from 2 to 4 times a year, and also have telephone calls where there's a chance to learn some of these techniques, to share best practices, and really be a support group. And over time, what usually happens in learning collaborative is that maybe in the beginning, the trainers do much of it, but over time then as in some ways the clinics become the experts because they have the frontline experience. They've now going through what works and what doesn't work, so they become the experts and they just teach each other. It's a website that has some of their training materials here. So, it's not magic, but there's sort of a concrete process here. A trainer, though, has to have sort of a model in terms of, well, what are they going to do in terms of what are they going to teach? And so the trainers for this one, they ended up having these so-called 8 change concepts. There's 4 of them here. So engaging your leadership, and develop quality improvement strategy. A lot of it has to do with like basic implementation science. So what do you need to do to change any organization over time? Type of empanelment, a continuous relationship, evidence-based care, patient-centeredness, enhanced access, care coordination. So that was their attempt there. So what are the results? So like when we've, Sarah's part of this evaluation where we looked at a whole different variety of evaluation outcomes. So it's sort of mixed. The quality care outcomes are mixed. Some improved, some didn't improve. Overall, cost utilization care did not change. There was modest improvement in patient experience. However, one key thing is that where there was benefit, it did tend to occur among the sickest, highest risk patients. In some ways, this makes sense that oftentimes when you design an intervention, it's a epidemiology principle that your biggest bang is often going to be where it's the patients who most need it. So among the sickest patients, there was a decrease in preventable hospitalizations and hospital costs, and there was an increase in patient empowerment and activation among racial ethnic minority patients who were in fear or poor health. Important too, there was decreased provider job satisfaction in the clinics who had decreased medical home capability. So the change process itself can be stressful and challenging then for providers. And then so that's our project. If you want to look for like the overall literature, this is website of this group, the Tenant Models Collaborative, that has more information. So I refer you to that. They have a nice website with articles and reviews. And the overall literature, it's pretty similar to what I said for our project. Quality, cost, and utilization mixed results. In general, increased use of GPs or primary care providers, inconsistent findings on specialty use, emergency department visits, hospitalization. And the longer a practice is at to the transformation, the sicker the patients, then more likely a positive effect like cost savings. I'm going to skip this and go straight to ACOs. So I think it'd be fun to talk about because I don't think it has somebody that's really comparable here. So it's people are interested in hearing about it. So accountable care organizations, what are these? These are provider-led organizations with a strong primary care base who collectively are accountable for the quality and cost of care for a group of patients, a population of patients spanning the continuum of care, meaning spanning inpatient setting, outpatient setting, home care. Your payment is linked then to your quality of care and reducing costs. And so it assumes that you have some type of sophisticated performance measurement system that's going to enable you to be able to do better in terms of improving your care and reducing costs. So President Obama, as part of his healthcare legislation, like about 6 years ago, actually created some governmental plans to create these ACOs. So the first one's called the Medicare Shared Savings Plan. And what I'm going to do with the next series of slides is show you like different flavors of ACOs to give you a sense of the type of variables that could be, in some ways, like altered if you're trying to, in some ways, test then what might lead to the best outcomes. And again, the incentive payments ACO gets are basically determined based upon how they do compared to a historical benchmark. So if you do better in terms of you save money, that's good. You'll save some of that money. If you do worse than that, that's bad. You won't benefit. And so initially they had these so-called two payment models. One-sided means that you can only benefit. So if you have shared savings, more than 2% savings, you would share those savings 50-50 with the government. You pocket half the savings, and then you give the other half back to the government. The two-sided allowed you to save more, up to 60% of the cut. The downside was then that there was now two-sided risk. If you lost money, you would have a financial penalty. Whereas in the first one, if you lost money, the government pays. But you could, if you gain money, your share of the profit was less. One fear is that people would say, well, you're just going to cut costs and then cut the quality of care. So there were also these quality metrics. You had to do well on these 5 different quality metrics, otherwise you wouldn't get the bonus, even if you had saved money. Here's another flavor now. So in this particular version, you could now get up to 60 or even 75% of the savings. So you could potentially gain more. The kicker here was that you'd also be given a so-called population-based payment option, so that besides the fee-for-service payment, some of the money would come up front in terms of like on a per beneficiary, per patient amount per month, you get additional money, which you would hopefully invest in the infrastructure needed to improve care and lower costs. So for example, someone like community health workers, so Sarah mentioned in her slide the role of these health coaches, that is traditionally not paid for in the U.S. healthcare system. If you had an innovative payment scheme that gives you money to basically hire health workers from the beginning, maybe that would lead to reduced costs. So that's another example. A third example, this one you could actually pocket all the savings if you did well. And the additional thing here is that besides those other forms of payment, capitation is added, where you get then like an overall global budget, and then that organization is then responsible for paying all the money and all. Again, the government is trying to get people more to this far end in terms of at full risk, all capitated. So that's what they're trying to gear people towards. Another option that just came out is accountable health communities. The idea here is that a lot of the outcomes of patients are driven by their social needs, especially in the high-risk populations. So these create more flexible funding streams where you can use some of the money for things like housing or employment or urban planning or whatnot. So what's the overall results in the literature? So very early literature, but here's the bottom line. Modestly less cost for ACOs, improved patient satisfaction, sort of like medical homes, the gains are seen predominantly in the high-need, high-cost populations. Quality of care outcomes mixed. And interestingly, at least in the government programs, still a net negative cost to the Medicare program when you add up the cost of running the program plus the shared savings they need to share then with the ACO. Then there's this issue here of like, sort of like, some ways like a number of key issues you need to think about in terms of like designing hopefully good policy, because in some ways well-intentioned policies can easily go off the rails here. So one tension is the tension between clinical integration and limiting market power. What do we mean of that? You might think about something like an ACO where the more integrated it is, the better it would be. That if the doctors are well coordinated with the hospitals and is well coordinated with like home care, well, you probably should be able to give more coordinated care, better outcomes, more efficiencies. The danger, and one of the dangers, is that the more you start creating these big entities and starting to lump these independent practices in these big entities, you basically raise the risk of monopoly. If, like, say, like in Dunedin, it turns out that, well, as opposed to these dozens of medical practices, you now have 2 mega ACOs that are now running the market. Well, this fear then of like monopoly power and the ability of those entities to basically raise their rates because they don't have competition. And interestingly, to give you an example of how all this stuff is played out, is fascinating. In the early Medicare ACOs, they looked at 2 different types of organizations. Ones where the physicians were independent from the hospitals, and those were those in which hospitals were a very powerful part of the ACO. So it turns out the savings tend to be greater in the ones that have independent physicians. And probably what's happening here is that if you're an independent physician that's not linked to the hospital, well, if you basically prevent a hospitalization, you pocket the money. It's on your total interest to basically save money there. Say you're a hospital where half of your payment comes from an ACO and capitation, and half of your money comes from fee for service. Well, if you create some great system that decreases all your hospitalizations, you make money on the ACO part, but you lose money in terms of your fee-for-service patients that now aren't being admitted to the hospital. So it's the two canoes passing the dark problem. Another example is that there's this question of how much risk does an ACO need to bear to basically change the behavior. So in other words, how much financial risk is necessary to basically motivate behavior. So Oregon, actually these are 2 states that you were at. So Oregon, they have a program which has a lot of risk, where all capitation, global budget, and so you're fully at risk. Colorado's ACO program was more like some of the early ones I showed you, where it's not full capitation, so it's not much financial risk. Study just came out in these two states. Turns out the results are very similar. So all to say that money and risk bearing isn't the full story here. And part of it is that, like, a lot of what we do, I think, in healthcare is both an intrinsic motivation part in terms of like money, but a heavy intrinsic motivation part in terms of the vast majority of people in healthcare are doing it because they want to basically help people and doing it for the right reasons. And so the Colorado program, they had a heavy emphasis besides the financial part in terms of the programs to improve quality of care. And that's, I think, what appeals most to providers. Let's skip the last one there. Yeah, we'll skip this. And I will end with this cautionary tale. How many of you met Sarah's husband, Brian? 3 or 4 people, yeah. So Brian is a really interesting man. He has a fascinating background, and he's a very interesting person to talk to. And so Sarah and Brian had kindly invited me to join them one Saturday morning to walk on one of the beaches in the north. You probably will recognize this place. It's called a maw. Is it maw? The mole. Mole.
Oh, the mole.
The mole, yeah. And so I'm intently talking to Brian, and Sarah's in the back taking these pictures. And Brian was telling me, well, in this particular mole, this particular beach, there happen to be rocks where seals like to come. And he said, well, you know, seals can be hard to spot. So you see, I'm looking intently at Brian, and Brian's looking straight ahead. My ears are looking at the ground. Sarah's just taking pictures happily away. What this doesn't show is that, like, literally like a second later, Sarah says, "Marshall, look out!" And it was just in time. I sort of leaped back, and as the seal was sort of leaping at me, but it was actually pretty close.
It was.
Which, you know, I actually literally laughed when it happened. But as I was taking pictures, I began to realize this could have been really bad. In fact, Sarah said, "Well, you know, you may have had your introduction to the ACC system here in New Zealand." The killer seal. And so, certainly, I guess the allegory here, or metaphor, is that, like, there are these opportunities that are right in front of us to improve care, lower cost, and more efficient systems, but we may not even sort of see them. And one of the dangers is that these, if we don't sort of take advantage of these opportunities, it can bite back at us. That the cost of care, or quality problems, or safety problems are nasty problems that make a big difference in people's lives. But the good news is that, well, the killer seal can be tamed, so there is sort of hope in terms of making our systems more integrated and more coordinated, improving care, lower costs. So that's it. So we have a few minutes for question and answers. Yeah.